All right, why don't we get started? I again want to thank everyone for joining us today. I'm Scott Podolsky, and Jen Cusetti, Carol Benoit, and I have been organizing this series of webinars related to how we can view the COVID-19 pandemic through a social medicine lens and act accordingly. Again, we've focused on who gets sick, what meaning we ascribe to such illness, and how we respond, both individually and collectively. All of this unfolds atop existing social structures, burdens of disease, and healthcare systems. And much of our response has been predicated on shifting and often contested models regarding the near-term and longer-term course of the pandemic and its linked health and economic consequences. This has been hard enough to model and respond to in the United States, but as today's speakers have stated, the lack of data and informed models for low-income countries compound the unprecedented challenges experienced in high-income countries. Once again, we're fortunate to have experts within our department who have long wrestled with the application of mathematical models to disease and economic dynamics, and who have paired such models with consequent global health implementation efforts. Matt Bonds has a PhD in both economics and disease ecology and is assistant professor of global health and social medicine at HMS. He is the co-founder and scientific director of Pivot, working with the Madagascar government to establish a model health district based on integrating clinical programs, system readiness, and data at all levels of the system. Karen Finnegan has an MPH in epidemiology and a PhD in international health systems, is a research associate at HMS, and is the associate scientific director of Pivot. Together, they'll demonstrate how novel forms of data acquisition and modeling in Madagascar have the potential to inform control strategies in other rural, low-income countries where transmission dynamics and risk profiles differ from the current evidence base in Asia, Europe, and the United States. They'll be followed by Paul Farmer, our department chair and erstwhile anchor of these webinars, who has consistently reminded us how we can apply the lessons of prior pandemics and these presentations to how we consider the present pandemic from multiple and mutually influencing biological and social standpoints, and how we can use such analysis to intervene more justly and effectively moving forward. We'll then have time for Q&A. As with prior weeks, audience members can submit questions anytime through the Q&A button at the bottom of your screen, and I intend to sort through those and then direct them to our speakers at the end. So let's start with Dr. Bonds and Dr. Finnegan.
Thanks, Scott. I'm assuming you can hear me. Karen, why don't you give me a thumbs up if, all right. Yeah, this is like a real special moment for us because so many of the issues that the world is wrestling with, from the questions of the ability to forecast the disease dynamics and the burden of disease, to how we quantify and measure that in real time and respond to that, to what the economic implications are for policies. Those are all issues that are near and dear to my heart. Like, they're the kind of central tensions of the work that have governed my own career goals. And usually, and I'm sure many of you who are on this webinar now can relate to, is usually we feel like we're talking in different languages, right? So, if we have a big outbreak in Madagascar, like plague or measles, the world may notice and they might support it, but we are in a different conversation. So then we have to come up with solutions on our own. But right now, it's like the exact opposite, as we know. So the disease is first emerging in middle and wealthier countries, and the world is mobilizing, and we can learn from that. And we're having the same conversation across the world about what to do and how to do it. So that's just a special moment, both intellectually and just from a public health perspective. So I thought I'd start with just a general overview. This is something that everyone's quite familiar with. This is just like, I just pulled a random COVID tracker. This one's produced by, I think this one's produced by Microsoft. But we know that, the first cases were detected in December of 2019. There's now been over 2 million confirmed detected cases. We all know that that's probably a radical underestimate of the actual global impact. And we've seen the death toll sort of rise globally. Here's a summary of just a handful of countries that we're probably all tracking: the US, Italy, China, and South Korea. It might be worth noticing the y-axis here. So in the US, in the upper left-hand corner, we're seeing almost 2,500 detected COVID deaths yesterday. South Korea is in the single digits. China is also in the single digits, and Italy seems to have the death from COVID plateauing and on the decline. So much has been made, of course, the process of this epidemic, of what the models are telling us and what the responsible response should be. And I think we're all quite familiar with Neil Ferguson's group coming out with their model in mid-March that predicted, potentially over 2 million deaths in the United States, 500,000 deaths in the UK. Others like Mark Lipsitch earlier were predicting a global pandemic that could affect 40 to 75% of the global population. Those models are of a particular tradition of models. And the U.S. governments and governments all over the world have responded. We've had these non-pharmaceutical interventions. We've had these lockdowns, and then we've had this sort of really fierce response. And these are fierce responses from people who I would say are in our existing community, people that we know and sometimes even work and collaborate with. John Ioannidis had a well circulated response, a fiasco in the making as the coronavirus pandemic takes hold. We are making decisions without reliable data. He's right. I don't think that's debated. We don't have reliable data. A little more controversial was this editorial in the Wall Street Journal by Iran Bendavid and Jay Bhattacharya. Is the coronavirus as deadly as they say? And so those are actually in response to the policy, to the mathematical models and the policy response to those mathematical models. Since those other models have come out, the most notable is the UW model. The so-called UW model. That'll be one incidental outcome of this epidemic as people start calling models according to the universities. The UW model from IHME, and that is a very different kind of model that is designed for different purposes. It's not an infectious disease model. What they're doing is fitting trends in the data that they see internationally to the US. And then just to give a sense of sort of how complicated this conversation has been, I'm sure everyone is paying attention. This is just a screenshot I took from a Fox News interview with Ali Muqdad from the IHME, who said the worst is over. That itself elicited a pretty big outcry on social media, not because the peaks in the US aren't over, but because what's in front of us are what look like, according to infectious disease modelers, two bad choices, which is continued containment and social mitigation or resurgence. So people like me, who's as an infectious disease modeler and an economist, don't see the worst as over. I see the worst as in front of us. So this got, I have no idea how closely everyone's following all this, but I'm following it super closely. Intellectually, it's actually quite constructive in general to see what all the epidemiologists and others are talking. And but I thought things went off the deep end this weekend when Tyler Cohen had this very provocative blog post in Marginal Revolution titled, "What Does This Economist Think of Epidemiologists?" And he closed with some pretty provocative language that is, I'm smiling, but I wasn't smiling when I read it. Now to close, I have a few rude questions that nobody else seems willing to ask. And I genuinely do not know the answers to these questions. A, as a class of scientists, how much are epidemiologists paid? Is good or bad news better for their salaries? B, how smart are they? What are their average GRE scores? There's outrage around this, and I was actually quite disturbed by it as an economist, epidemiologist. And the reason was because up until recently, the sense that I had had from how the global intellectual response had been was super overall constructive, right? It's actually kind of amazing. Economists are actually dabbling with epidemiological models. I think that's great. They have quantitative skills. It's great to bring them on board, to contribute to them. the global conversation is moving quickly. We can inform each other's work. Data collectors and modelers and technologists and innovators and public policy people are having a very constructive conversation. And this struck me as a sign that that there are bigger barriers, the old traditional barriers that I feared, which are just kind of, what do you want to call it, disciplinary barriers, might be as hard as ever. And there might be a lot of angst or acrimony around that. So some of what I want to talk about now is in response to this. I talked to him, Tyler Cohen. As a coincidence, you may not know that he's also in charge of the FAST Grants program. Didn't know that myself, but and I honestly, and then I started listening to his other podcasts on COVID-19, and I want to share, for what it's worth, that that I think people like him are way closer to what we might think, and these are actual questions. I mean, they're most, as he calls it, he's dropping a grenade. They're certainly the most provocative. They're not just questions. They're begged questions, right? Which is like, how important are your GRE scores to being effective policy responder, or how important is quantitative methods, et cetera. But actually, he's not actually a skeptic of the epidemic. What he's trying to do is he's wrestling with policymakers himself and is getting frustrated. So I was actually quite heartened after talking with him and just learning more about sort of when he's behind closed doors talking to other economists about COVID-19, that I still think we're actually extremely close, but I do think there's a lot of misunderstanding. I don't think people understand what it means to have an infectious disease model. I don't think people even necessarily know what the communities of epidemiology are. So that has informed a little bit of what else I wanted to talk about. So I'll highlight first that obviously one of the big problems with this particular pandemic is that we have our hands tied behind our back, right? We don't have a vaccine, we don't have therapeutics. It's a novel virus that most people are susceptible to, and the data are horrible. And so the arguments over how fast it transmits, how fatal it is, what the health system capacity is, what the policy implications are, that's based on not a lot of solutions and not great information. Not good enough information. So just as a little bit of background, for those who don't know, which I think is a lot more than I appreciated, the infectious disease models that you're seeing coming out of people who probably call themselves quantitative epidemiologists, who model things like COVID-19 or influenza or whatever, that comes from a very specific modeling tradition. And it's actually an 80-year-old, probably longer, modeling tradition. And it had a revolution in the late 70s and early 80s because of Anderson and May. And they're close to my heart. They're ecologists, they're theoretical ecologists. And the theoretical ecologists got really interested in infectious diseases because they're biological systems. They're interactions between multiple species, and of the kind that you have probably better data for than many other biological systems. So Bob May, who was actually trained as a theoretical physicist, who became a theoretical ecologist, and Roy Anderson, who was a theoretical ecologist, took on these questions around, okay, well, can we ask really interesting, hard, important questions about the dynamics of biological systems by studying infectious diseases, using models that are similar to actually predator-prey models. Now this is taken over, so the kind of models that you'll see at the Harvard School of Public Health from Mark Lipsich's group or Bill Ferguson's group, or anyone who says infectious disease model is probably using this kind of system. The updated version of Infectious Disease of Humans that Anderson and May wrote was written by Matt Killing and Pej Rouhani. Pej Rouhani is my PhD advisor, and I was in his lab when this book was being written, and I read the manuscripts of it multiple times while it was being produced. So this particular tradition is very close to me. And so I think I wanted to share a few things. Like, one is, for those there's a lot of model skeptics out there because models are imperfect. And I think, of course, the question we always have to ask ourselves is, well, what's the model trying to answer? Or at least what kind of light is it trying to show? is it doing that, and are the assumptions useful that for it to conclude what we need to understand. And what I'll say is, like, as a bias, I like on the surface of it, the kind of problems that we see of COVID-19, that kind of system is kind of tailor-made for these kinds of models, right? COVID-19 is a directly transmitted disease that transmits kind of broadly, and a kind of what we call sometimes a mass action approach, right? It's indiscriminate. It's not a sexually transmitted disease that has really complex social structures or contact structures. It's not a vector-borne disease that depends on the dynamics of like mosquitoes or flies, or it's not a waterborne disease that requires so it's actually the history of infectious disease modeling for which what we're seeing, for which all these systems have been like calibrated and trained and estimated, that have been used for things like flu and SARS, whatever. This is actually kind of the best circumstance for which infectious disease modelers can get involved with. So as a starting point, I would say if you're inclined to be dismissive of them, don't. Doesn't mean that the modelers are right, but it does mean that this is like a system, the kind of system that these models were made for. This is my whiteboard. I have a whiteboard at home. I got one just in the last couple weeks since we've been stuck at home, and I thought I would just share a few basic concepts of what a typical infectious disease model looks like. So Megan described this a little bit a couple weeks ago, Dr. Megan Murray. The classic story here is that you divide the population into categories, those people who are susceptible, those who are not infected and susceptible, some process of those becoming infected. Sometimes there's a latent period, sometimes there's not. And then some process of recovery, if recovery is possible. And sometimes, sometimes is quite relevant, is mortality effects. So you've all seen language around this. So Megan described this a little bit. So the basic concept of R naught is just the rate of transmission divided by the rate of clearance. So in this case, this gamma represents clearance. So 1 over the clearance term, that equals the infectious period. So it's the rate of transmission time, the amount of time that we have to be transmissive. So anything that increases the rate of clearance or shortens the infectious period by, for example, mortality, lowers R naught, which is why Ebola doesn't have as high of an R naught as we might think because of the mortality effects. So it might be worth noting that the definition of R naught people are starting to use it all the time, sometimes well, sometimes not. So R naught's considered to be the number of secondary infections from the first infected individual in a totally susceptible population. So if you're not in a totally susceptible population, so if you're in the middle of an epidemic or if you're in the middle of policy responses, usually we'll use a term, something like the term R effective. So that's what this left thing is. And R effective is lower than R naught. Why? Because the number of susceptibles in the population goes down over the course of the epidemic. So the concept of herd immunity, which many people are aware of, that is defined as 1 minus 1 over R naught in most systems, right? So this is actually a really useful term. So if we know R naught, then we know how many people in the population are necessary to be no longer susceptible for the disease not to continue. So for example, if R naught is 2 and half the population is vaccinated, or if half the population has already been infected and is recovered, then the disease can no longer continue. So for what it's worth, I just pulled a few examples of R naught estimates. These can range pretty widely, actually, depending on the system and population and the context. But as many of you may have seen, estimates for COVID-19 or people are landing has been in the order of around 2 to 2.5. Those estimates have gone up and down, and obviously one of the big challenges with this is the data. We don't have good accurate data on detected cases and incidents. So those estimates sometimes might underestimate the actual value of that. And so others are starting to use death information explicitly in these SIR models. I've even seen some people refer to them as SEIRD as in models where that's modeled explicitly. So here's just sort of some some estimates of where our effective is. So as the epidemic is growing, as social distancing is working, we're seeing that the disease is no longer able to infect more than one person over the course of an infectious period, and so the epidemic gets smaller. So I thought like these kinds of concepts get, can get much more complicated, but the fundamental concepts don't change. I thought I would just share one manuscript that we have just submitted, not because I think it's super important to this conversation, but because I think my collaborators would be really mad at me if I didn't give them a shout out. Callistus and Gogala, who did a postdoc in our department, Global Health and Social Medicine, now professor of mathematics at Florida. And Abba Gumel, who is a mathematician at Arizona State. We've recently produced this manuscript that estimates all these things from mortality information, where the D term is explicit in the models from now over the reproductive rate. We've seen the reproductive rate. We've seen doubling rate happen fast. I'm getting a note that my internet connection is unstable. So Karen, if someone isn't hearing me, let me know. So no one's arguing actually that like this isn't an adequately.
Matt, can you go back about 1 minute to the previous slide and just repeat that part?
Yeah, sure.
Okay.
This one?
You got it. Thanks.
Okay. The take-home message here is simply that we submitted a manuscript of models that can be much more complex than simple models. We use data on death rates, which is modeled explicitly from New York and other parts of the US. And we use that to estimate things like the effective reproductive rate using non-pharmaceutical interventions. The results themselves aren't breathtaking. The analysis is pretty rigorous, so we identify mathematical conditions of the system. So no one's arguing that the R naught is less than 1. That's like self-evidently the case as we see the doubling rate. The real arguments have been, what are the mortality effects? And there's big debates over how you estimate case fatality when you don't have enough detected cases. That's what's happening in sort of the US and Europe. Those where those fierce debates are happening. But what does this mean for developing countries? Well, there's a number of factors, as many of us are quite familiar with, but they're worth highlighting, that might be very important to determinants of the severity of the disease and the transmissibility of the disease, that we're all well aware of, that we know are going to be quite different for low-income countries. Things like age, which is super important, gender, comorbidities and co-infections, water and sanitation, contact structures and transportation systems, climate, economic conditions, and health system capacity, all quite different, in some cases radically different, in the places where we work, like in Madagascar, than they are in the United States, Europe, and Asia. So just as one example, here's the COVID-19 death rate by age for Wuhan, from Wuhan data. And on the right, that's on the left, on the right is the age distribution in China. Age distribution in Italy, where we saw where almost a quarter of the population is over 65. Here's the age distribution in our district in Madagascar. This age distribution is almost exactly like this throughout the rest of the country of Madagascar. It's exactly like this throughout sub-Saharan Africa. Almost throughout sub-Saharan Africa, you're seeing between 2 and 3% of the population are over 65 years old. So obviously that is going to be important for what we know about the severity of the disease, but we don't know how important given the other comorbidities. If we look at death rates of COVID so far in sub-Saharan Africa, here's some examples from Ghana and Kenya and other countries. What we're seeing is almost no information is the bottom line, right? We don't know what's happening here, right? Obviously, we have low rates of detection, and we also have fundamental concepts of like how fast the disease can spread. We have less urban environments, but we can. I think the take home here is we're in an information vacuum. So so these are also countries that have generally responded sooner. So in Madagascar, for example, policies have happened, social distancing has happened in a way that perhaps earlier than the epidemic has taken off in those countries. So these are huge issues. So I want to quickly talk about our opportunity. So when I think about, as a mathematical modeler myself, and as someone who works in a health system in Madagascar, and as an economist who sees sort of the social consequences of these policies, I'm pretty concerned, right? You know, we have these sweeping policies of the kind that that are going to cause a Great Depression of sorts, right? That are costing the U.S. Just call it as a rough number, $2 trillion to prevent, through non-pharmacological pseudo-interventions, the transmission of a potentially fatal illness for a lot of people. And basically, countries like Madagascar are implementing the same policies, right? We're shutting down transportation, we're discouraging people from social gathering, we're preventing people from moving, which is, of course, how trade occurs. And we're doing it with almost no information on who's infected, where they're infected, and even what sort of the risk profile will be. And so we're doing it in a context where the risks, the upside risk, the downside, depending on how you think of it, the downside risks are much more significant, right, of getting it wrong, right? So health capacity is much lower. Many more people living on the margin of survival. So this concerns me because it's possible the Institut Pasteur Institute in the capital can produce, can evaluate 200 tests on a daily basis. That's a national lab. It's impossible for that to keep up with the need for detection. So in the middle of the epidemic, even if we're delaying the epidemic over the course of months, weeks, hopefully months, we may not have any idea, to be honest. We may have no idea whether we're in the epidemic, whether we're avoiding it or not, right? Well, the other kinds of indirect consequences are people are going to health facilities at less. Right? So we have people who are avoiding health facilities. We have people who have less economic, whose livelihoods are affected for an epidemic that is modeled out of Asia, with modelers in the UK, in the US, with unsure consequences. And not only do we have forecasting models that are unclear, but we don't have the data to update those forecasting models. And I'll say that's like, which frightens me maybe the most, because I think it's the least excusable. Right now we're set up to experience the whole epidemic over the course of weeks and months, maybe longer, and not ever have known what the transmission of the disease happened. Right? We may do seroprevalence studies. Those will of course happen across sub-Saharan Africa, and we will get some concept of exposure. We'll have very little information on the morbidity consequences of that. Right? We're not doing seroprevalence on people who die. Right? So we're looking at a situation where a pandemic is going to happen, and we may not be able to meet the moment. So, very small, very, very, very small silver lining. When we started Pivot in the Finnegan district in Madagascar, we set it up with a central thing in mind of how do we make sure we have the information to improve the quality of services, to inform policy, and to produce information that is useful globally. And we have really strong, integrated clinical and data systems and unique testing capabilities to help get a little insight into this in one corner of one district that is fairly representative, broadly speaking, of the nation of Madagascar. So this is what Madagascar looks like. This is actually a Finnegan district, which like I often say symbolically looks exactly like the island of Madagascar. Don't be confused. This is very typical of a health district in Madagascar, and in many ways of health districts throughout sub-Saharan Africa. So there are many community health workers who are distributed across villages at the level of what's called a Fokantani in Madagascar. It's a network of primary care centers that officially supervise the community health workers, and there's a district hospital for secondary care. So this district hospital deals with complications, certain kinds of emergencies, health center, of course, deals with primary care, vaccine, a lot of preventative activities. Community health tends to specialize on under 5 and reproductive women, but they have other functions as well. So our niche has been from the beginning surrounded around the integrated concept of implementing health systems. So this includes infrastructure and clinical programs, data system in a way that improves policy. And so there's as rapid feedback as is imaginable that to help improve those systems in ways that make a difference. So just as sort of as just one example of the kind of data we have, this represents utilization at primary care facilities based on per capita utilization from villages throughout the district at primary care facilities over time. You can see the time on ticker on the upper left. So right now, this is what a health center looks like. This is run on a health center. Here's some clinical programs at a primary care facility. This is a district hospital, supply chain, maternal ward. And we take all these, all this information and we put it in a dashboard, and we have very close to real time understanding of a lot of information from case load to supply chain issues. And importantly, as population-based researchers, we collect there's like an inappropriate, we collect a lot, Karen's about to laugh. We collect so much data, let's put it that way, a lot of data across the population. And the reason why we do that is, and we do this through a longitudinal cohort study. So we're tracking 9,000 individuals over time, representative sample, and we collect a lot of information from geographic information systems. So all those things that you saw that we think are potentially super consequential for the outcomes of something like this, those are kind of data that we collect from sanitation to gender to age, those things, to climate issues, those are things that we're tracking very closely throughout the district. Moreover, we've mapped every footpath in the district. We know who's accessing care and who's not, what the probabilities of those are, what some of the determinants of accessing care are when people present symptoms. So just as one example, the left here is a network of where people are coming from villages to primary care. Those nodes are primary care facilities. We thanks to work from Thelna Ihantamala, who is a postdoc in our department, Global Health and Social Medicine, and Andres, who used to be a postdoc in our department, Global Health and Social Medicine. We're building our team of extremely talented researchers, and we've actually estimated the travel distance from every village, every single village in this very remote population to every community health site and every primary care center, and track exactly the time it takes to get from one place to another using various kinds of mechanisms, including OpenStreetMap, with rainfall, without rainfall. So we have a lot of information on who's getting care and how they're getting care and what to do about that. Moreover, one of the reasons why we chose to work in this district is that this model district includes, can you imagine, a biosafety level 2 infectious disease lab. This was actually one of the initial attractions that brought us to this because of the capacity to do more molecular and clinical kinds of research that we might not otherwise be able to do as epidemiologists and data science type people. So this is an actual photograph of that lab. This is funded by Jim and Robin Herrnstein, who are actually co-founders of Pivot, Jim was the first chair of Pivot's board. Robin is now the chair of our board. And this is all part of the initial justification of doing this in the first place, an integrated science, population health system initiative. So to give you a teaser of like the kind of things that we think we can do around COVID is this is an example of not quite finished malaria estimates at the population level from facility-based information. So we take information, we weight that information based on the exact details of where the person is coming from, and we statistically model what we think the incidence might be of, in this case, malaria across the district. Do this for every month of the year. We're rapidly working on building out these kinds of models. This is work that was led by Lizzie Hyde and Andres. So this over to Karen.
Matt, can you just go back about 20 seconds to the start of that slide.
Sure.
Actually, it's Karen start. Thanks.
Karen, you're muted.
Thanks. Scott, do you need to go back to a previous slide for Matt or this one?
This slide's perfect.
Okay.
All good.
So I'm going to talk a little bit about the questions that we're trying to answer in Finnegan District in conjunction with the clinical team and the policies that they're implementing. As Matt alluded to, we have questions about the prevalence of the disease in Finnegan District, as well as the rate of spatio-temporal spread. We're interested in looking at the determinants of morbidity and mortality related to COVID, and we want to anticipate the expected workload for the health system and understand if the decisions that Madagascar is making clinically and socially have an impact on transmission of COVID. Our research strategy is that we are going to combine data from the health management information system that comes from the community, from health centers, and from the district hospital with testing information about antibody prevalence and other seroprevalence data, with special data sets like geographic information systems and the longitudinal cohort study to inform the models that look at transmission, morbidity, and mortality. As Matt mentioned, Finnegan District is special because it's a place in which the Ministry of Public Health, Pivot Healthcare NGO, and Center of Albio, or CVB, are all working. And so that means that there are resources that are in part unique to the location, and then some which are part of the general health system. So this includes rapid diagnostic tests for testing for COVID, which are supplied by the Ministry of Public Health. And those are available for patients who present at health facilities and meet the suspected case definition. We have filter paper and other materials for 4,500 dried blood spots, which were intended to be used for the 2020 iteration of the cohort study, which has been put on pause for now. And so we can use it to collect data, to collect information about the presence of COVID antibodies in blood. There's a gene expert machine at the district hospital, which is most often used for tuberculosis testing, but we're hopeful that sometime in the summer we would be able to use it for COVID testing. And as Matt mentioned, there's a BSL-2 lab at CVB, which includes, among other things, a freezer at -80 degrees. So in Madagascar currently, there are just over 100 cases of COVID throughout the country. The first case was confirmed in mid-March. There have been 0 deaths, and in Finnegan District right now, there are no cases. The closest cases are in Finnegan, which is a city about 90 minutes away, and there are 7 cases there now, all of which are hospitalized, as well as their contacts are in isolation. Despite the relatively low number of cases, Madagascar responded swiftly. There was an initial lockdown of the capital, Antananarivo, and there have been a pause on international and domestic air travel, and travel by bus has stopped from the capital to rural districts in an effort to prevent the spread. There are health checkpoints which are established at district boundaries to screen for cases, and at the health checkpoints there's information about where people are coming from and a temperature check. Madagascar's closed schools and universities and has canceled public events, and there's a call center has been developed where people can call in for information, and there are radio campaigns to help disseminate information. In addition, there are posters which include information about signs and symptoms and prevention of COVID transmission. This is one of the health checkpoints where the temperature is collected. So Finnegan District is preparing for possible COVID infection. As under the normal health conditions, community health workers are really frontline workers for the primary healthcare response. And so Pivot and the Ministry of Health are working to adapt clinical protocols so that community health workers can continue to provide usual care, like care for under 5s, antenatal care, and family planning, with additional precautions to prevent the transmission and protect the community health workers. In addition, this week, community health workers were trained on the signs and symptoms of COVID and instructed on when to refer patients to health facilities for care, and provided with information to help educate communities about transmission as well as prevention. Health facilities are preparing for triage, diagnosis, and treatment. And this includes the use of rapid diagnostic tests, or RDTs, for testing, as well as the collection of samples for PCR analysis. Currently, most samples are being run in the national laboratory at the Institute Pasteur in Madagascar, but there is an effort to decentralize this analysis to regional laboratories. And the guidance from the government is that there should be isolation for mild and moderate cases and known contacts. Right now, cases in Ifanadim district, if they were to be identified, would be referred for care outside of the district to the nearest hospital in Finnegan, but eventually care will likely shift to the district hospital as the caseload increases. And the government, as well as the clinical team, is working on developing protocols for contact tracing for the close contact of confirmed cases. Pivot is supporting all of these procedures, as well as helping to support procurement of tests, PPE, and other supplies. I want to share with you a few photos of preparation. So this is Ranamafana Health Center, and you can see that hand washing stations have been set up, as well as on the ground. There have been markings made so that people are standing adequate distance apart as they line up to wash their hands before coming for usual care or for with concerns about suspected COVID infection. And health workers are preparing to make sure that they are protected as we work to deliver PPE to the district. We're making precautions, and there are mask making projects that are going on currently. In addition to the clinical team preparing, the monitoring and evaluation team is preparing. The Pivot's monitoring and evaluation team is working with the team at the district health office, as well as the national government, to develop forms that will be used for collection of suspected information from suspected and confirmed cases, as well as their contacts. And data will be collected in 2 ways, on paper forms or through a modified version of the ComCare app, which is the ComCare COVID app. There are only 4 health centers in the district hospital. These are in green or blue in the bottom of the map, that will be entering data directly into the ComCare application. The remaining health centers in orange will be collecting information on paper forms, and then those will be transferred to the monitoring and evaluation team for entry into the database. These health centers in orange don't have network coverage, and so there's no way to sync the information. And so paper and then later data entry is the best way to collect that data. This information is being collected in part to inform a dashboard and for the monitoring and evaluation team to track what's going on and feed back the information to the clinical team in real time. I want to stress that this is a prototype that I'm about to show you. There are currently no known cases of COVID in Ifanadim district, but the team is building this prototype to practice and to see the functionality of the dashboard. This is Pivot's usual dashboard with an addition now of a COVID-19 module. And you can see that they're tracking cases as well as their outcomes, and both where they're located as well as over time. And you can drill down to various levels and receive more information about the geographic location of these cases. So this information is being collected about patients who come in and may be suspected or confirmed cases, but we have lots of questions about people who may not be coming for health care. And so we need to think about not just looking at to COVID patients for information to answer our research questions, but to other populations. When I started, I outlined our research questions, and those we're interested in looking at prevalence, at spatio-temporal spread, and morbidity and mortality, at anticipating expected workload needed to meet this epidemic, as well as knowing whether or not the interventions have had an impact. And so we think about our research as looking not just to COVID patients, but also to their contacts. And as contact tracing is not yet up and running, we think about looking to the accompaniers, the people who come in with the COVID patients, as a proxy for those contacts in the early stages of our research. We're interested in non-COVID patients who present to the health facilities for general outpatient services as standing as a proxy for community prevalence, since we're unable to do a household survey at this time. And we think about healthcare workers as providing information about sentinel surveillance and helping indicate when COVID does arrive in Ifan district, as they're most likely to be some of the first to show signs and symptoms of the disease. So we're interested in answering these questions, and we think we have these groups of people who are who we could look to for some of the answers. And then we start to think about, with the resources that we have with CVB, the lab, and with Pivot, and with the Ministry of Health, what exactly can we collect feasibly and ethically in time as the epidemic unfolds? The cells that are in bold indicate that this is part of normal clinical care. And so this data, this information would be collected as part of the clinical process. Things that aren't bolded are additions that the research team would add. And you can see that we're interested in collecting demographic and clinical information from all of these groups, as well as rapid diagnostic tests. We're interested in collecting nasopharyngeal swabs and testing them or freezing them if tests aren't available. These swabs are part of our procurement process. They're not yet in country. And so realistically, it's probably about 6 weeks at a minimum before we could start collecting that data. But as I mentioned, we do have the materials for dried blood spot data collection. And so the idea is that we would start collecting that type of information from people as soon as possible. And then while we're collecting information, we hope to collect capillary blood and freeze it so that as analytic techniques evolve, we're able to do additional analysis in the future. That's our immediate response to the epidemic, and where we think about collecting information to help answer our research questions and to inform the clinical programs of the best response and where their resources are needed. In the spring of 2021, we will tentatively hold the next round of the longitudinal cohort, and we would add a seroprevalence survey to that to collect better population estimates of prevalence of COVID-19. We're interested in using the HMIS data that's collected as part of the routine process to understand the impact that COVID has had on usual care seeking in the district. And as I mentioned, we'll be freezing blood to develop prognostic and diagnostic markers and to understand the biology of the early immune response. I'm going to hand it back to Matt to talk a little bit about the model.
I used to throw mute. Yep.
You can hear me now. Can you see my screen?
Yes.
Okay, great. Thanks. So we just told you, we just shared with you, I should say, sort of some of the things that we're doing now, some things that we intend to do, some of the big questions. And so in addition to the work around the clinical response and the data collection, we're rapidly working on the actual models themselves. So this is actually a mistake. You can see this model has been reproduced 3 times in this slide. But we've been working with John Drake's lab and Clissus Ngongala, John Drake from the University of Georgia, and Clissus Ngongala from the University of Florida, and Michelle Evans around using the kinds of models that we are done for modeling COVID dynamics everywhere in the world, and and designing them according to the kind of data that we think we can collect in Madagascar and estimating the parameters that are relevant in Madagascar. I am not going to go into these actual results because they're not trustworthy. They're not real parameter estimates. What they do is they show the models are generating predictions, and on the bottom right-hand corner are the reason there's multiple lines is because of the way the models are run. These are stochastic simulations, so we look at probability distributions of the parameters at the outset and look at multiple simulations. And so what you can see is that the forecasted models are above what we're detecting. What we want to do over time is make sure these models are fitting the data really well, so as best as possible we can understand the dynamics in this system. So I'll say that, like, let's see if, so last year there was an article in Science Magazine around this kind of work that we're doing in the Fontaine district. And the theme of the article is a theme that is dear to my heart, which is to do good science in global health. It really does, it can help to do serious implementation. And likewise, to do serious implementation, it can help to have access to the right kinds of data that can inform what we're doing and change policy. And this kind of system, this kind of model system, we think is one of the kinds of environments where we can shed light on this problem, is where we have the pre-existing routine data systems or routine clinical situation and the ability to respond as quickly as possible. So I'll just say that sort of the key conclusions here is that we are truly in an information crisis, and it's orders of magnitude worse for low-income countries. We really are in the dark, and we are at risk of being in the dark the entire time throughout the pandemic. And if we link the clinical response with rapid testing and analysis to inform clinical care and policies, and we can link those to inform policies in Madagascar and beyond. And this is super urgent, incredibly urgent, like where it's already late, where, you know, anyone who's interested in supporting this in any way possible, of course, that's what we need. Thank you.
Great. Well, thank you to both Matt and to Karen. I mean, the infrastructure that you've so painstakingly put in place is to gather real data, which will be so important moving forward. We're fortunate to have Paul Farmer, our department chair, who has anchored each of these webinars now, be able to weigh in as they discuss it. So Paul, we're excited to hear from you.
Thank you, guys. Thank you so much, Karen. And Matt, you too, I suppose.
Good to see you, Paul.
Good to see you both. First of all, every time I hear about Pivot and see even the most passing photographs of this place, it enchants me. So I can't wait to get back there. I hope it's okay for me to go back to the big picture a little bit, and to not to push back, because I don't have anything to push back on. I would that we could all gather this kind of data in real time. It's really more to stand back, not push back, and say, okay, what's going on now in Madagascar right now? What are you going to be able to capture? What are you going to be able to avert? What are you going to be able to, lessen the pain of, et cetera? Because, the fans of Pivot have already true believers in the model, already true believers in the ability to gather information that not only may be of interest, will be of interest. And so I guess what I would say is, let me back up and talk COVID as a new pathogen in a place that you know very intimately, and then ask, well, what can you do for the people you're serving, but also for the rest of us who are watching and want to know. We want to see that information system come into play and, artlessly deliver as if it's some Rwandan drone delivery. Deliver us some oxygen, some staffing plans, some contact tracing, and a turnaround on the COVID epidemic.
Yeah.
So I guess that I want to find a sweet way to say that, and a sweet and well buttressed, challenging way, because there's all the resources that are necessary have already been marshaled, right? So we have a population that now we're getting to know very well, that has had a number of studies done of it in addition to the services being provided. And again, it's hard to study what you're altering, but that is the case that you've made, being good, sentient, and ethical people. So we're facing. We know a little bit about the key vital statistics of this region. We know their life expectancy. We know who lives, who dies. We know more or less how it stands in for other countries in sub-Saharan Africa, maybe more like Sierra Leone than parts of Rwanda, et cetera, et cetera. These are things that you know. Now, there is a baseline burden of disease, which is a lot. It's a lot of malaria. It's a lot of other problems. It's a lot of, blood sapping, life stripping pathogens. There are also problems with food security. No real functioning safety net, except the ones that you're putting in. And now we have all this known and well described and about to be slammed. There isn't expected to be immunity. We know something about the case fatality rates in populations with that curve. I mean, it's not like we know nothing after 4 months. And we have some ability, Matt told us, and you sounded a little bit like Trump, Matt. You said as rapid feedback as unimaginable. Next, I was going to hear something like the perfect system. It's the perfect letter. Come on, where's your smile, Matt?
I'm waiting.
All right, so this system is perfect. Every footpath traced, every bent blade that is trodden by a community health worker. Now, let us know how many cases of COVID we're going to have, what their clinical severity is going to be, what are the supplies that are needed to have on hand, whether those be oxygen, basic nursing care, antipyretics, and then how we're going to lay out the contact tracing task so that we can find where grandma's hidden, since you have such a conveniently loved young population. But we know she's out there somewhere. We know there are a lot of vulnerable folks out there. So how are we going to link the system to the new need, not the need that you've already well demonstrated you can respond to? And this is not, how can we help to do this too? Because it's hard for us to believe that, you can tell us things about Ghana, Senegal, Kenya. We know there's no testing going on. So why would we have a great deal of confidence about how many cases there are? So I guess what I'm saying, Matt and Karen, is bring it on. You said there's a modeling war. I don't even see like a little skirmish. Let's have a modeling war. You've got a disease that you say has been set up for this kind of a model. We've got a lot of baseline data. We have a new pathogen. We have stuff on supply, that we're going to need to respond. So what's that going to look like?
All right. Can you hear me?
Oh, very well.
Thanks, Paul. This is obviously what you're here for. These are obviously the central questions. We probably weren't clear enough that on the clinical side, we are working with the national government. We're ordering PPE. We're ordering oxygen and preparing and training staff. The question that arises is, right now, in the absence of prophylaxis and better therapies, the solution is what I would call is a social economic solution, right? Which is social distancing.
Well, wait a second.
The policy.
Okay. I'm just saying, yeah, I mean, the whole world is functioning under this assumption. Agreed.
This assumption.
But there's
and
also,
should we be doing that when we're, as the epidemic is unfolding?
No,
but this is, it's to say you understand is like it's not that you don't understand. We don't know the answer to that.
I said I understand the question.
In 2 months we could not know the answer to that, and we'll be in a situation where we won't know if the epidemic has passed and the population is recovered, or if it hasn't. And we'll be looking. What we will need is some combination of like lots of testing, and then some level to make with poor representative sampling, some kind of population-based estimates to inform how we prepare for things. Are we ramping up on the curve, or are we on the other side? So I think the central question here is, in addition to just the question that obviously testing is needed to know whether COVID is the explanation for people's illness, or if they need to keep looking,
or even if they're
also just like, what is the optimal policy response? Should we shut down the economy? And to know, I mean, it's possible that the disease actually doesn't even make its way through these communities. That's possible. And so we need to know that. And there's no way to know that unless we test it and then start coming up with ways of using those unrepresentative samples to understand the population spatial dynamics.
Yeah. Well,
so it's central to like having the society function again.
Yeah.
Is how I would say it. And
again, that is not a challenge unique to Madagascar. It's the one we're facing here.
Yeah, exactly.
And
exactly
everywhere. So I assume that you're going to ask that question and point out that it hasn't been. We don't even know if it's the right set of policy interventions for a place like Madagascar. Of course. Now, I was also saying, back to the much vaunted data collection system. Just say that you're in Haiti, and you have 15 or 2,000 patients a day coming to point X in Mirebalais, right? And all the things that I was talking about, oxygen supplies, PPE, nursing, staffing, food, just the basics like that. In addition to answering the big questions about social and economic policy, I was just saying, are there going to be answers to questions like how much PPE you need? Where is the oxygen concentrator going to best be placed? What about the under 5? What is our protocol for contact tracing? That's the only reason I'm asking is because it seems to me that these are tasks for right now, not for 6 weeks from now. But
sure. We do that. I mean, so those are really important. We actually do model those the actual health system capacity. The reason I didn't produce those models is because they're not trustworthy models, and so they're like heuristic. I mean, they're essentially heuristic models. I mean, they're explicit, but they're borrowed from other places. So the idea of these models is you can forecast if you know about things about the transmission, and then anticipate what the needs will be, and then the actual health system capacity needs. PPE, physical capacity, and then also look back and look at contemporaneously at what the burden in the population might be.
And let me just and I feel like there are lots of other people who need a chance to get in here now, but in not dissimilar to what I mentioned last time that you presented, you have this ability that very few other places on the verge of a significant biosocial event have. You have the ability to measure things that others don't. And I just wonder if, again, if you could just step back and have others who are not just looking at the materials that you'd normally collect, but is this going to be anything like 1918 Madagascar? Because if it is, this is going to be a massive wallop to the society, urban and rural. I mean, that's what happened in West Africa in 1918 at the height of the so-called sultry hot season where these pathogens were supposed to disappear. You know, it hit the cities and took out 4% of the population of Freetown. So if something like that does happen there, and you're going to be there with your monitoring systems, I just wonder if it's possible to stand back, and even without all of the testing parameters worked out, to know that you're about to witness something and to describe that as best you can. Anyway, I know that you're doing that already. I think there are probably others who wish to ask questions or make comments.
No, this has been a very generative back and forth about these twin needs to both acquire data, but also to be able to react in real time, and to see that play out. Karen, I want to make sure, did you have anything to add to that?
Karen, can you hear that?
No, I think that's exactly right. And you know, I feel like we work really closely with the clinical team exactly because of questions, and deep right now in IRB time, it feels fairly distant, but the calls with the clinical team every day really keep you grounded in exactly and just how in Madagascar, where they're not preparing with their Instacart order and putting things in freezers and able to easily work from home remotely. It really feels like these are really critical and very important decisions, and that the research is needed now more than ever to be really high quality but speedy.
Yeah. Well, I mean, if you can take any, I know that, Karen, this is just like my teacher said to me, but if you can keep a field diary or just take notes, you know, a lot can happen suddenly, of course. And you know, there's enough of a laboratory system to register it, and just vital signs of people coming in. You know, I wasn't thinking of Amazon Prime or anything that could happen here, but really the Haiti situation, they've already lost one of their intubated patients with COVID, you know, and whereas a few days ago, there weren't any, there were very few Haitians with the disease. Anyway, I feel like others must have things they'd like to say, but I am on triple tenterhooks waiting to see what's going to happen and hoping our friends are okay.
So we only have a few moments. Matt, did you have any final response to weigh in with either Karen mentioned or Paula mentioned?
No, I mean, just that that Paul, appreciate your really important reminder that obviously the point here is that the clinical response can work. I mean, obviously that is that it's actually what the whole organization is oriented around, and what, as Karen mentions, is the daily focus. I can't get beyond the information vacuum that we're using to just not know if patients are going to have COVID-19, you know, like whether knowing what's going on in the rest of the population, how many people have antibodies is sort of like is everything to the story around like whether the mitigation strategies might actually be working. And just from a population health perspective, this information gap seems so central to solve, to take one foot in front of the other in a rural district like this. And it's not representative of the entire continent, but we hope that it is representative of a lot of the island, and representative of some other parts of rural, low-income rural communities that are remote.
Absolutely. Yeah. This reminds me more of the, you know, the hurried pace of decisions that were being made in West Africa during 2014 and 2015, as opposed to what's going on here. But Anybody can be an anthropologist.
I don't think so. I heard it was a skill. I read that somewhere.
Anyone can be a historian, but thank you all. And one of the slides that you had shown was on the impact in Madagascar of COVID-19 on existing care and chronic care. And that'll be the subject of next Wednesday, rather than Thursday. It'll be next Wednesday's noontime seminar. We'll be hearing from Jean Buckman and from Raj Punjabi on the impact of COVID-19 on existing primary care practice and on chronic disease treatment more globally. So obviously we'll welcome everyone back next Wednesday. And thank you again to Karen, to Matt, and to Paul. Thank you.
Thank you, guys.
Thank you. Thanks, Paul.
Thanks, Karen. Thanks, Matt.